Hola! In this episode, we will discuss General Anesthetics. The first anesthetic nitrous oxide gas was discovered by Pease in 1976. It was first used as anesthetic by dentist Horace Wills in 1844 for the removal of tooth in human. On the other hand, C.W. Lung discovered the anesthetic effect of ether in 1818. It was first publicity demonstrated in ether dome by William T.G. Morton in Massachusetts General Hospital in the year 1846. In 1846, Wendell Holmes coined the term anesthesia. In 1847, James Young Samson introduced chloroform anesthesia. Anesthetic cause anesthesia meaning loss of sensation resulting from reversible depression of function of nerves. In 1872, chloral hydrate was the first intravenous anesthesia. In 1903, barbiturate was introduced. In 1929, cyclopropene was discovered. In 1935, thiopentone was introduced as general anesthesia. When we say general anesthesia, it is reversible loss of sensation of the whole body accompanied by the reversible loss of consciousness. Next, regional anesthesia, reversible loss of sensation of large area of the body without affecting the consciousness. Local anesthesia, it is a reversible loss of sensation of particular limited area of the body. Surgical anesthesia is usually used in surgical operation, a state of anesthesia under which the animal is normally deep sleep without responding to the painful stimuli. Balanced anesthesia, it is a safe general anesthesia ensuring the satisfactory loss of sensation, motor reflexes, and many others. Basal anesthesia, a lighter level of anesthesia produced by the pre-anesthetic depression. Inhalation anesthesia required special equipment like Boyle's apparatus, mask, etc. While the IV anesthesia required only a hypodermic syringe and a needle. Here are the theories of general anesthesia. First, lipid solubility theory of Overton and Mayer 1901. Wherein compound with high lipid solubility easy penetrate the CNS being rich in lipid and alter the function of nerves. We have also the surface tension or absorption theory of Traube 1904, microcrystal theory of Pauling and Miller 1916. We have also the protein binding theory of Frank and Lieb 1982. This anesthesia act a reversible binding of hydrophobic domain of protein. We have also the receptor theory, which interacting with the neurotransmitter receptor. And ion channel theory is a kind of anesthesia bind to the voltage-gated ion channel and reduce excitability or promote inhibition of nerve membrane. Clinical response of an animal to the administration of inhalation anesthetic is divided into 4 stages in order to assess the level of the CNS depression. The level of depression progress in the order of cerebral cortex to the midbrain, spinal cord, and finally the medulla, wherein there are 4 stages of anesthesia: the stage 1, stage 2, stage 3, and stage 4. In stage 1, this stage starts from the beginning of anesthetic inhalation and lasts up to loss of consciousness. The sensory cortex is depressed, but all sensory reflexes are present. In stage 2, this stage starts from the loss of consciousness to the beginning of regular respiration. The depression extends to the motor cortex, but all sensory reflexes are present. And the stage 1 and stage 2 are collectively comprised induction of anesthesia. In stage 3, this stage extends from onset of regular respiration to cessation of spontaneous breathing. And depression is extended from the cortex in midbrain to the spinal cord. Divided into 4 planes, plane 1 and plane 2, light surgical anesthesia, plane 3 and 4, deep surgical anesthesia. But most of surgical operations are done in plane 2 of stage 3. In stage 4, this stage starts from cessation of breathing and extends till cardiovascular failure and death. And it is called the stage of medullary paralysis. Here are the classification of general anesthetic based on the route of administration. In inhalation anesthetic, we have the volatile and gaseous anesthetic. The next one is the parenteral anesthetics. Thank you. Adios.